So I hope to share some of my experience over the last 15 years with OPTIFAST. We have two parts today. Part one is the screening and assessment for treatment and active weight loss. And then part two is talking about maintenance of weight loss or weight management. Part one is the vast majority of our slide deck today. And we're going to split up part one into two main parts. One, I'm going to talk about the evidence, and two, I'm going to talk about the OPTIFAST program itself. So let's go ahead and jump in. So I think the key to any type of treatment for any individual in medicine, regardless of the disease state, but just like other diseases, obesity is no difference. One size does not fit all. And we're going to go through some, general guidelines on how to treat patients, but in the end, it always comes down to looking at the individual in front of you and doing what's best for them. And sometimes you may have to modify, tweak things to do what's right for your patient. We always want to do what's best for them. So, we can figure that out from looking at the history, the physical, lab results. We look at their behaviors, things they've tried before, try to determine obstacles that patients have dealt with, what's worked for them. I try to look at my patients when they come in. I'm not their first stop for weight loss. They've typically have tried multiple times before. So I try to figure out what works for them, what doesn't work for them, because there's no reason for me to try to slam down something down their throat that doesn't work for them. Let's use the things we know that do work for them. So, definitely look at the material I provide today as some, good general guidelines, but always tailor it to your patient sitting across the room for you. So I'd like to start with the evidence behind OPTIFAST. And that's what I think really differentiates OPTIFAST from other programs is they've got a long history. I believe it's 1974. And yes, that was before I was born, that they've been around. And they have a number of studies, peer-reviewed journals, randomized trials showing safety, efficacy. And so that's one of the great things behind OPTIFAST. When I'm providing this type of program for my patient, I know I'm providing an evidence-based program for them that's going to provide results. So I want to first jump into one of the pivotal trials. This is actually the OPTI-WIN trial, which I was invited to participate in a few years ago. We published it in 2018, and it compared an OPTIFAST program of 12 to 16 weeks of complete meal replacement to a food-based program that was it was modeled after the diabetes prevention program. So a lot of you may be familiar with the diabetes prevention program, but it showed efficacious, significant weight loss greater than 5%. And so we looked at these two groups, the OPTIFAST group, 12 to 16 weeks of a full fast, and then 6 weeks of transition to a maintenance diet. The food-based group was in 26 weeks of weight loss, and then they moved to 26 weeks of maintenance. And these are the outcome differences that you can see. You can see that at the end of the active weight loss phase, about twice as much weight loss. And even though a little less weight loss at 1 year, still about twice as much weight loss. So definitely showed significant efficacy. Also, the trial showed really good tolerance to the program. The dropout rate in the OPTIFAST program was actually not any higher than in the food-based program, and we didn't see any significant adverse events compared to the food-based program. And we like to oftentimes break out, weight loss instead of just looking at these average weight loss here, which we often get fixated on, this 10.5% and 5.5%. What we like to look at, though, is categories of weight loss, because 10.5 is just the average. We know that some patients do very well, and there's some people that are super losers that lose 15%. There's some people that really struggle and only lose 2 to 3%. So we can break that down. And you can see here on the left, 26 weeks, on the right, 52 weeks. And you have 5% or greater weight loss. And the reason 5% is important is because that is what's considered medically significant weight loss. If you can break 5% weight loss, you can demonstrate some improvements in cholesterol numbers, hypertension. You can show improvements in diabetes control. Obviously, more weight loss is better. And you could look, if we look on the right side here at 52 weeks, you can see in the OPTIFAST program versus the food-based, more hit that 5%, same thing at 10%, and same thing at 15%, all statistically significant better than the food-based group. So 1/3 of those patients in that OPTIFAST group could be considered super losers. I mean, breaking 15% weight loss, which is fantastic. So it's sometimes nice to look at these breakouts compared to just looking at the overall percentage, because as anyone who treats obesity knows, some people really thrive in a program and other patients may struggle or have more difficulty in losing weight. The next trial is not OPTIFAST based, but it is a meal replacement based program, and this was done out of the United Kingdom. This is the DIRECT trial. So this was a trial done in the United Kingdom, and they wanted to look at new onset diabetics. The new onset was considered looking at someone who's been diabetic for 6 years or less and not on insulin. They used a meal replacement program, about 850 kilocalories a day versus a control group. And this was an amazing study because they were able to show remission in type 2 diabetes in nearly half of the patients, so 46% at 12 months. And even going out 24 months, you still had 1/3 in remission. And remission was considered an A1C less than 6.5 without any medications for at least 2 months. And so the United Kingdom, actually, the National Health System there, NHS, actually expanded after this DIRECT trial to do an even bigger, look at several thousand patients. And this may, eventually, at least in the NHS eyes, become part of the standard of care, that perhaps treatment of diabetes starts with a meal replacement program to help put it in remission. So we'll see where that goes. But definitely there's a shift in looking at the importance of diet and weight control with treatment of a lot of the chronic diseases. These are other studies that look at other benefits of an OPTIFAST type program, meal replacement program, weight loss, and that is the change in fatty liver disease. And anyone who works in a bariatric surgery program definitely sees the benefit of using meal replacements or liquid meal replacements, a couple weeks before surgery, helps shrink the liver and reduces risk with surgery. So likewise, we see improvements in fatty liver disease with an OPTIFAST type program. So that was just some of the evidence behind why we use OPTIFAST and why I like using OPTIFAST in our program. Next, I want to talk about the program itself, a little bit of the philosophy. How do we get patients started in there? The history evaluation, developing a plan, and then transitioning the patient back to regular food. So the philosophy. So the philosophy is that obesity is a chronic disease. It's dangerous and complex. It really needs to be treated by a multidisciplinary team. This isn't something just to be treated by Oprah or a late night infomercial. Nothing against Oprah, she's fantastic. But this really needs to be treated as a complex disease process. And when we use stimuli narrowing through dietary intervention, which is what OPTIFAST does, and combine that with nutritional counseling and support and behavior therapy, patients do very well. And I think the key here with OPTIFAST is not a product. There's lots of meal replacements out there. I mean, you go to the store nowadays, there's a whole aisle of just meal replacements. It's crazy. When I started doing this 15 years ago, there was hardly anything out there. But OPTIFAST is not a product, it's a program. And you have to have all pieces of the program for it to work. And we really, go over that with our patients, and definitely when I, teach other providers about it, you really need to have all the pieces of the puzzle. It's not some magic shake that's going to fix everything, as some people think. So let's talk about stimuli narrowing. So this is the process of limiting variety and quantity of foods to help decrease appetite. And studies show that the less variety of foods available, the lower the calorie intake. And I think we've all experienced this, right? We've all been to Thanksgiving dinner or a big party where they have lots of different choices, maybe an hors d'oeuvre table with everything out there. and or lots of sides, and you feel full, but you know what? You just got to have a taste of that, and you want to have a taste of that. And, I'm not hungry, but I just got to have a taste of this. And so, this stimuli narrowing by controlling the sight, the texture, the flavors into a narrow band really helps our patients with appetite. And I think that's one other thing that's different with OPTIFAST than maybe some of the other commercially available meal replacement programs out there. Some of these meal replacement programs some of them have, I think, close to like 100 different products, and they come in chips and dips and puddings and puffs and everything you can imagine. What we find with OPTIFAST is that when we narrow that stimuli, patients do very well with hunger and appetite control. So this is the strategy. So the strategy is to have medical monitoring. So you have to have that multidisciplinary team. We do the stimuli narrowing. We have behavior modification. So those are your classes, your group support. We're doing a lot of that now through Zoom. Education for our patients to learn strategies to be successful long-term. And that's really the key. The key for our patients is to have long-term change. And in our program, we call it a 2-year program. So we ask our patients to sign up for 2 years worth of this multidisciplinary team and classes and support. And then once they sign up for that 2 years, we tell our patients we lied to them. It's really forever. So they really need to look at this as a chronic disease. So I tell my patients, if you're not following up with me after 2 years, you need to be following up somewhere after 2 years, because this doesn't magically go away. We want to set them up for long-term lifestyle change, and we can help get them on the road in the right direction. So this is kind of it in a nutshell if you look at it. So it shows active weight loss phase. So active weight loss phase on a full meal replacement. So a full meal replacement is as little as 800 calories a day, which is 5 OPTIFAST meal replacements, and that comes as a shake, a bar, or a soup. And they can do 12 to 16 weeks on that. Transition phase is usually 4 to 6 weeks, and then you talk about weight maintenance, 6 to 24 months. So our program is a 24-month program, but over half of our patients continue beyond 24 months, and I've had some patients with me well beyond 10 years. And they may not be following up every week for weigh-in, that far out, but they may be seeing me once or twice a year. They may come and see a dietitian or a class here or there, but they always know we have an open door here, that during maintenance or weight management, if they need help, that they can come in for help. The transition it has here is 6 weeks. You can see, that's highly modifiable. Most of our patients do well beyond 6 weeks of transition because most are not at their goal at 6 weeks. We provide behavior therapy. There's lots of creative ways to do that nowadays. And the other part of the program is the medical monitoring. So obesity typically doesn't occur all by itself. Obesity is typically surrounded by other diseases related to it, other comorbid conditions that you see every day: diabetes, hypertension, sleep apnea, arthritis, you name it. So when we're seeing our patients, we're not only monitoring their obesity, but because improving obesity may improve all those other conditions, we keep an eye on them. And we'll talk about that later in terms of keeping an eye on medications and the need to modify that. So originally, they always talk about 12 weeks, but there are studies, and in the OPTI-WIN trial, we definitely did go out to 16 weeks for complete meal replacements, and that's what the data shows in the OPTI-WIN trials and some other trials. Personally, in our program, we allow our patients to go up to 6 months on a complete meal replacement. So our patients can go up to 26 weeks before we make them transition. And it's just dependent on the comfort of the medical provider and the patient, if that's something they want to do, or if we want to stop earlier. And we even allow patients to do shorter stints. So, if at 4 or 8 weeks it's time to transition, we'll work with them. Once again, going back to that first slide, about one size doesn't fit all. You have to work with your patients and do what's best for them. Now, one thing that's interesting with all these talks about treating obesity, we always see this nice linear line. You plug someone in here, they do the program, they come out here, and they're fixed. That's nice, and it'd be great if it was just an assembly line where we just pump people in one side, they come out the other side fixed. But in reality, this is like other chronic diseases. And so this is what we typically see. And I see this in my clinic every day. We have active weight loss. We go through a period of transition. We go through a period of weight management. And I like to use the word weight management, not weight maintenance. Maintenance sounds like, maintenance on my car means, I just drive my car every day and then once in a while I got to do something for it, but I don't really have to do much. It just kind of takes care of itself. This is really active weight management here. For patients to maintain weight loss, they have to actively manage their weight, meaning utilizing the tools, the resources, the behaviors that they learned during the active weight loss and transition. So I think that's important. I know it sounds like it might be, splitting hairs between management and maintenance, but I think it's really important in terms of the concept when explaining that to patients and even many of our medical colleagues. Many of our medical colleagues still think this is a disease of, gluttony, and that everyone should be able to fix this by pushing away from the table without understanding really how complex this disease process is. So patients really need to work on weight management. And then just like other diseases, just like patients that I treat with asthma or patients I treat with heart failure, you can have exacerbations. You can have a flare-up. And so I like to call it an obesity exacerbation. I know other terms, and you'll see that in the slide deck here, say relapse or recidivism. Having a legal degree, we always studied recidivism in terms of criminals going back and repeating criminal behavior. And so I always hated that term when we talked about people with weight regain, recidivism, like, it was all their fault, like they chose to regain that weight. And obviously their behaviors oftentimes play a role in it, but it's much more complex than that. And so I like to use the term an obesity exacerbation or flare-up. And patients, every single patient that loses weight will have some of this. And what I tell patients with this cycle of treating obesity is we want to minimize this obesity exacerbation. We want to keep that to days, weeks, maybe a month. And that's why we look at treating obesity as this chronic long-term partnership, where if they do experience any of this, there's no blame and shame. They feel comfortable giving me a call and getting back in that office as soon as they're ready. So some patients may not be appropriate for a complete meal replacement or may not choose to do a complete meal replacement. And so we do a partial meal replacement with them. So with a partial meal replacement, it's typically 2 to 3 OPTIFAST a day. Sometimes we do 4. Lower BMI ranges, lower weight loss goals. Patients that are very high risk, maybe a type 1 diabetic where managing their insulin may be a little more difficult. Patients that just say, hey, I need to eat food, I need to chew more, those bars aren't enough. And we use a lot of this for extended therapy following the initial phase. So, if we have patients that need to lose 100 plus pounds and they do 12 to 16 weeks, and obviously, usually we're not at goal at that point if they're trying to lose that much, we'll transition them to a partial meal replacement and perhaps keep them on that for 6 months or a year or however long we need to. And with this type of program, you could also use prepackaged foods for their meal a day or for some of their snacks, just to help control portion size and control nutritional intake. In our office, so we do have an OPTIFAST program here, but we provide everything that's evidence-based for weight loss, including the option for bariatric surgery. But in terms of medical weight loss, probably 60% of our patients, 70% of our patients do a complete meal replacement, maybe 20% do a partial, and 20% just do a meal plan without any meal replacement. So we do see the benefits of this and do utilize it. So let's talk about the medical history and evaluation. So what kind of evaluation do these patients need? It really is more of a targeted approach when you're looking at patients. And first of all, you usually want to establish the risk level. And why this is important is this help guides the follow-up to some degree. Now, once again, going back, and I'm sorry, I sound like I'm repeating myself, that one size does not fit all. That applies to follow-up. So obviously, I use some of these criteria to kind of know where patients start, but follow-up is individualized in our office. So the low-risk group are patients without significant diagnosis, lower BMIs, not on medications, typically your younger patients. So these are your 25, 35-year-olds, 40-year-olds without any other medical problems. Your high-risk patients are your patients with, the diabetes, the hypertension, they're typically higher BMI, they're on medication that you need to monitor, and we'll talk about that in a few minutes. And you're looking at other risk factors that we know they have, so you got to keep a closer eye on them. So patients you can see less often, patients you need to see more often. And even though, these criteria look set, once again, you have to do what you and the patient feel comfortable with. So what are some of the absolute contraindications? Who are patients that really should not be on a complete meal replacement program? So if they're pregnant or they're breastfeeding, if they're active bulimia or other type of eating disorder, active alcohol or drug abuse. I've actually had this twice. I had a patient that came in, was drinking a 24-pack of beer a day, but he wanted to do OPTIFAST with me. So obviously we told him he had to work on other priorities first. Recent acute pancreatitis, untreated major depression. So we take care of patients with depression, patients with a history of bipolar depression all the time. They just have to be well treated, meaning they're stable. They're not actively having any suicidal ideation or homicidal ideation. If they have other serious acute illnesses, so obviously, someone just got out of the hospital that's on antibiotics for treatment of their pneumonia, wait till they're stable. Someone undergoing cancer treatment. Recent MI or other cardiovascular events. So in the last 6 months, if they had a heart attack, a stent, a stroke, a blood clot, you may want to wait. If they're normal BMI, they're not appropriate for OPTIFAST. And if they have an acute malignancy or current chemo radiation treatment. Relative contraindications. So these are conditions you need to look at, inflammatory bowel disease, if it's a flare-up, it's not controlled, active hepatitis, active renal disease, that sounds pretty broad. We treat patients with renal insufficiency, chronic kidney disease every single day of the week. As long as they're stable, we treat them. Recent, major fracture that's healing, we don't want to maybe interfere with the healing process if we reduce their caloric intake too much. Any significant endocrinopathies that are not treated. Chronic cardiovascular disease, that means something that's not stable. Most of our patients have risk factors for cardiovascular disease, but if they're a stable CHF, a stable patient with coronary artery disease, you can treat them. And then inappropriate for group sessions. So we still treat those patients with the OPTIFAST program, but we modify the OPTIFAST program for them. We may not have them do group visits, we may have them do some one-on-one visits. And why are people inappropriate? It could be, personality issues, schizotypal personality, people with, agoraphobia or don't want to be in crowds or in a group setting, which actually is everyone right now. And so we modify things for those patients, but you wouldn't put them into a traditional, force them into a group if they were not comfortable there. And then when I do a history on a patient, I want to get the obesity specific history. Once again, going back to what I said earlier about, I don't want to have to reinvent the wheel for my patient. If there's things that my patient knows doesn't work for them, I don't want to force them to do that again. Or if there are things that do work for them, I want to go down those paths. So, things we want to know is when they first started gaining weight. Was it rapid, gradual? Oftentimes we ask them to kind of draw a timeline with their weight gain over time. And a lot of time that's not only insightful for us, but it's insightful for the patient to see if they gain weight with, relational issues or, other major life events or stressors. We want to know their highest and lowest weight in adulthood. And then, recently what's going on? Are they stable? Are they gaining, losing? You want to look at their complications and comorbid conditions, relevant family history, previous weight loss. So I want to know what type of programs have you done before? Have you tried medications before? Why did you regain weight after the program? How long did you keep it off after the program? So all those type of questions. The physical exam is pretty similar to what you do for most patients coming in. Now I really focus much more on the cardiovascular exam. So you're doing your anthropometrics, your general, your HENT. I typically am not doing an ocular exam, but you could. Definitely looking for signs of heart failure, definitely doing pulmonary. Abdominal exam, I really have difficulty performing an abdominal exam on many of my patients, so oftentimes I don't. I may look at their skin to look for stria or hernia or palpate, but trying to really get in there deep to feel liver or spleen on some of our patients can be very difficult. Definitely looking at their skin, there can be lots of signs there. The big one we find a lot of is the acanthosis, so it gives you some hints that the patient has some insulin resistance. You're looking for edema, peripheral vascular disease, and then any neurological. So really the main focus though is cardiovascular risk factors that you're looking for and signs of heart disease on exam. Baseline laboratory evaluation. The purpose is to establish safety. So you want to assess for any contraindications. So if a patient is, acute renal failure that's new onset or has some other type of issue that you need to deal with. You also want to look at and document a baseline so you can look for improvement in risk factors. Our patients, as many of you know, love looking at numbers in terms of, how their blood sugars are doing and cholesterol numbers. And so that can be really motivating for patients to see their baseline levels and then where they are at maybe 3 months or 6 months. And then also you're looking to identify any comorbid conditions that we may be missing. And we find this all the time, pardon me. Many of our patients will have, undiagnosed prediabetes or even type 2 diabetes, thyroid disorders. And so definitely, looking for those things is important. Identify those as part of your workup. So let's talk about medications and medical history. So we were taught in medical school, do no harm. And, obviously these medications have a lot of efficacious uses, but one thing they may harm is our patients in terms of their weight control. And these are big ones that we see. And what you'll see a lot of, definitely with your type 2 diabetics are weight gain with, your insulin, your sulfonylureas, and your glitazones. Weight gain a lot of times with your antidepressants. Antipsychotics are all the rage in psychiatric medicine. I mean, they do provide some really great benefits for our patients with depression, but they can also cause some significant weight loss. And I'm sure anyone out there that has treated obesity, I've seen patients gain sometimes 30 pounds, 50 pounds in 6 months to a year on some of these antipsychotics. Beta blockers can cause weight gain. So these are things to assess as you're, evaluating the patient. It doesn't mean we stop all these medications, but it's something you assess. I talk with the patients about. I let them know that some medications may be contributing to their obesity or making it more difficult to lose weight. That's not a reason for them to stop any of these medications without speaking with their physician. We will modify medications as needed for safety during weight loss, but we don't start day number 1 changing all their medications. So we just let them know. And I think this allows patients to understand that this is not all their fault, and that their experience with difficulty with gaining weight and losing weight, that some of these medications, so there's a medical background, a physiological reason why they may be having some of the difficulties they do have. And I let them know that, hey, we'll work with them to improve their health. So maybe they're able to have these medications adjusted or decreased or sometimes even discontinued by their other providers. So what do we want to avoid during the weight loss phase? So we're avoiding elective surgery during the weight loss phase. And the main reason for that is just the electrolyte, potential electrolyte disturbances with rapid weight loss. In my clinic, patients that are stable go to elective surgery all the time. So we do a lot of pre-surgical weight loss for knee replacements. We do a lot of pre-surgical weight loss for bariatric surgery, and they go from full fast into surgery. We just make sure that they're stable before they do that. Alcohol and recreational drugs are not going to help our patients with weight reduction, so you want to have them to stop that. Diuretics. So an OPTIFAST diet is definitely a lower sodium diet. Also, just decrease in carbohydrate intake and overall caloric intake will naturally cause diuresis. So when you start a patient on a complete meal replacement, 9 times out of 10, I stop their diuretics. And what I tell the patient is, keep an eye on your legs or your breathing, and if you think you need to take a dose, you can take a dose. but the vast majority of patients will not need their diuretics. If they stay on their diuretics and they diurese with the OPTIFAST, they could, get a little on the dehydrated side and cause a little acute renal failure. I had a patient that was doing 40 milligrams of Lasix twice a day, and when I told him to stop, he did not stop. He came in after 1 week. His creatinine went from like 1.1 to 2.2. I told him to stop his furosemide and come in a week later, and he didn't stop it. And the next time he came in, his creatinine was 3.0, and he was hospitalized. So you definitely have to let patients know they have to hold their diuretics. You want to avoid the pseudoephedrins, so it's a proarrhythmic. Sugar, alcohol-containing medications are going to work against us. So the antihistamines can definitely cause weight gain. And then aspirin and NSAIDs, so they're going to have less food in their stomach, so less buffer for the acid. And so, definitely if they're on high-dose aspirin or a lot of NSAIDs, they can definitely, develop some gastritis or irritation. If a patient needs to maintain a high-dose aspirin or high-dose NSAIDs during the complete meal replacement, I usually put them on a PPI, so like a Protonix or Prilosec, just to protect their stomach during the rapid weight loss phase. So when you treat obesity, we're not just treating the disease of weight gain. We're also treating the comorbid conditions that come along with it. Because as you know, first-line treatment for many of the other chronic diseases is diet and exercise. So you will see significant improvements in type 2 diabetes. So let's talk about type 2 diabetes for a second. So a rule of thumb for type 2 diabetic going on a complete meal replacement is if they are an insulin-dependent diabetic, we stop all rapid-acting or short-acting insulin, and we typically cut their basal insulin by 50%. And then follow them closely. Usually I have them send me their blood sugars after a few days, and then we make adjustments as necessary. The concern in the short term with type 2 diabetes is obviously much more a problem with hypoglycemia than hyperglycemia when we start out of the gates. Surprisingly, that adjustment for most of our patients is appropriate. So there's significant reduction in the need of insulin. You also have to watch for the sulfonylureas because those clearly can cause a hypoglycemia. So we typically stop the sulfonylureas in patients that are starting a complete meal replacement, and followed by the TZDs after that. Antihypertensives, we typically follow patients. We don't typically make dose adjustments day number 1. We just follow their blood pressure with them. Tell them to keep looking for signs and symptoms of orthostasis. So if they're getting up, getting lightheaded, we want to adjust things before they get to the point where the blood pressure falls too low. Warfarin. So the nice thing about this type of diet is the vitamin K levels consistent. So if they're on 800 calories, they're getting the same amount of vitamin K daily. So once you get that adjusted in the first few weeks, you should be good going forward. So anyone who starts, who's on warfarin, we check an INR that first day, so we have a baseline, know where we are, and then follow up at a week and 2. And then, if we're stable after that, we're good until they get back into regular schedule. You also want to watch lithium. So lithium is a salt, and because of the diuresis, especially out of the gates with a complete meal replacement, you do have to watch the lithium levels, so we will check that. Typically, other antidepressants on a complete meal replacement don't need to be adjusted. Sedatives, most patients do fine. But as weight reduces, they may need lower doses of some of their medications. So these are just to talk about some of the complications associated with or worsened by obesity. So these are some of the disease states that you're going to pick up on the history and evaluation, or history and physical. So pseudotumor cerebri or benign intracranial hypertension. We do have a lot of patients referred to us by the ophthalmologist, and the great thing is weight loss is curative for this for most of our patients. You got your respiratory, sleep apnea. We do offer home sleep studies right in our office just because we see so much sleep apnea. You got your typical cardiovascular issues that you see. GI, we're seeing more and more fatty liver and NASH referrals now that hepatitis C is being cured. Fatty liver and NASH is going to be the next leading cause of liver failure or cirrhosis. You see your genitourinary issues, gynecological, hematological. Too many of those we don't have to catch. Osteoarthritis. So as many of you know, many of the weight-bearing replacements in terms of knees and hips, the Academy for Orthopedic Surgeons is recommending getting the BMI under 40, so we're seeing a lot of those patients. Cancer, so it has breast here, but there's actually, I think, 13 different cancers now associated with obesity. And then, you'll see your endocrine disease, PCOS, and diabetes, which is probably, I'd probably say, at least 40 to 50% of our patients. So let's talk about setting the active weight loss plan. So factors to consider. So, why can't we just put patients on 800 calories of cabbage soup or 400 calories of the cookie diet or whatever the latest fad is? Well, what we're trying to do with this type of program is what they call a protein-sparing modified fast. So we're trying to minimize the loss of lean body mass. So patients can, lose weight on the scale, but if they're losing weight on the scale based on losing lean body mass or muscle, we may not be doing that great of a favor for our patients. So certain patients, tendency to, you want to watch postmenopausal patients will have more problems with lean body mass, lesser degrees of obesity, and then chronic steroid therapy. Definitely, you're going to see more problems with lean body mass. Renal failures. Let's talk about, renal failures. So most of our patients, if not all of them, on a full complete meal replacement, we're looking at 70, 80, 90 grams of protein maximum for the day. So the vast majority of our patients, that's still within realm of appropriate protein intake for renal failure. A lot of patients think that OPTIFAST is a high protein diet, and technically it's not high protein. Other considerations. So because of that diuresis that we see with weight loss, definitely watching patients with heart failure and renal failure, looking at fluid status. And so these are probably the patients that I follow the most closely, are patients with, you're looking at heart failure, renal failure, following the creatinines, looking for edema, looking for the need to add in more fluids or restrict fluids. And then once again, going back to keeping a close eye on those diuretics. And what you're trying to do is avoid, some of the patients, think more is better, especially when it comes to water. So you want to watch just for hyponatremia with some of these patients really pushing in water and washing out that salt. So these are the general guidelines for the minimum recommended physician visits. Once again, these are general guidelines. Every patient is individual. I plan my follow-up with my patients based on medical necessity. We are practicing medicine. This is not just a cookbook. So you always have to look at the patient. But generally, for patients that are at high risk, on a low-calorie diet, 800, 960, you're typically looking at every 2 weeks. At a higher caloric intake, the first month you're seeing them twice and then as needed. Low risk patients, you see them the first month a couple times, and then after that you can see them every 4 weeks. But once again, these are general guidelines. You should be using medical judgment of how often you need to see the patient for a physician visit. And then just going into that idea of you need to do what's medically appropriate for the patient. So if I have a patient who's 70 years old, on insulin, bolus insulin 3 times a day. They're on their long-acting Lantus at bedtime. They're put on an 800 calorie a day diet. I may see them weekly for 4 weeks, maybe 6 weeks, if that's necessary, because we're continuing to make changes in their insulin, which a lot of times you will be. And the good news is usually you're decreasing the insulin during that time. So these are guidelines, but you need to make medical judgment of how often you need to see the patient. If a patient comes in today and they report terrible diarrhea from the meal replacement, then maybe I want to see them next week to make sure that that's better. I'm not going to necessarily make them go out 2 weeks for their next visit. So these are general guidelines, but you should make the medical judgment of when you need to see the patient again. So what kind of things are we doing at the weekly visits? So these weekly visits can be done by, a dietitian, a medical assistant, a health coach. So really, we use a questionnaire asking patients about symptoms, how they're doing with their weight, if they have any issues that we need to bring to the attention of a medical provider. Um, our dietitians can review lab work with patients and activity levels. Our medical assistants don't, so it kind of depends on who's seeing a patient at a weekly visit. Um, Weekly visits, a lot of this, progress problems, reinforced behavior change we do in a group setting. Um, Adjusting the program. So this is great. That whole nice graph where we showed 12 to 16 weeks and then 6 weeks, we adjust things if we need to. So I tell patients, even patients that may be a little concerned about doing a complete meal replacement, you could always start down that path, and if we need to change it, we can change it. You can consider adjusting medications, record problems, trends, and advice. So these are some of the common things that you're going to see on a complete meal replacement. So that caffeine withdrawal is probably the worst. So those patients that really cut the caffeine out, you're going to see, some withdrawal from that. Other causes of headache can be the water intake, lower sodium intake, so make sure they're staying hydrated. Dizziness, once again, goes to hydration. Constipation, we'll use some fiber, or diarrhea. The fiber will help provide some bulking of the stools. You will see reduced tolerance to cold. So as patients lose weight, and definitely as they get further along, they lose insulation, their metabolism goes down. You do see increased tolerance to cold, reduced tolerance to cold. Dry skin initially, some menstrual irregularities, definitely out of the gates. Over time, that typically gets better. They typically get more regular with weight control. Pregnancy, so if a fair number of patients become pregnant, losing weight makes them more fertile. Fatigue, you want to watch for hyponatremia, thinning and loss of hair. So this is very common. I have at least a couple patients that come in every week. The good news about that is it's typically temporary. It's called telogen effluvium. So you sound real smart if you're able to say that word and give it to your patient and explain that's what's going on. Also, it's very reassuring that this is a temporary condition due to the stress of a dietary change, and it has nothing to do with them becoming bald.
There's a question, and how long do these symptoms usually last?
That's a great question. So most of these are transient. The hardest part of the program for any of our patients is the first 2 to 3 days. Once they make it through 2 to 3 days, they are typically great. And those 2 to 3 days is typically the headache and dizziness. The constipation, diarrhea typically takes their body maybe a week or two to figure out things. Then they tend to get semi-regular. The rest of these can occur anywhere along the way. But these are things that are common that you're looking for. So things you want to look for abnormal labs in the weight loss phase. So definitely with fluid shifts, you're looking for potassium, sodium levels. You can see some changes in the carbon dioxide. Uric acid, BUN, typically goes up with dehydration. So because of the diuresis with a complete meal replacement, you'll see sometimes some elevation initially of the BUN, uric acid, and even the creatinine. And that's just a reminder to ask patients to push fluids. Abnormal LFTs, we'll talk about that on a coming up slide. Anemia, we typically don't see that too often. Vitamin D is pretty common. Common medical conditions to manage. So I think we talked about all these, and once again goes to the point that obesity doesn't occur just by itself. It occurs with these other conditions. Diabetes, we talked about in decreasing the insulin dose, the difference between type 1 and type 2. So some providers will not put a type 1 diabetic on a complete meal replacement. It may be too hard to adjust the insulin and keep them appropriate. If I have a really motivated type 1, I'll slowly ease them into a complete meal replacement. Otherwise, we typically do partials. Type 2, we put them on a complete meal replacement all the time. And once again, the medications you may have to adjust, but the big ones out of the gates are your sulfonylureas and your insulin. Hypertension, we talked about the diuretics, and then just keeping an eye on signs and symptoms of orthostasis if you need to taper or reduce blood pressure medications as they move along. Bone fractures don't occur that often, but it's believed to be for appropriate healing. If they have a major fracture, we should take them off 800 calories, bring them up perhaps to 1,200 calories. Minor fractures, we'll keep them on it. Just make sure they're getting plenty of calcium, vitamin D. You sometimes see, some back pains and sometimes even some hip and gait issues, just as their body changes and how they carry their weight. They can experience some of these things, but most patients see an improvement in their orthopedic conditions with weight reduction. So I mentioned earlier about liver function tests. So we typically see 3 patterns. So we see some elevated LFTs on admission, which improve with weight loss. We see some sporadic elevations of LFTs. The cause isn't completely known. It's believed to be that maybe these people have fatty liver and you're getting the fat out of the liver, and maybe that's raising the LFTs. And so, this transient elevation LFTs usually occurs after a couple months, but then it, almost always comes down. It very rarely goes beyond 3 times the upper limit. If you're seeing progressive elevation of LFTs and they don't come down, then you're looking for other problems like gallbladder, hepatitis, something else. I don't go chasing abnormal LFTs if we see a little elevation. I know some docs that want to get to ultrasound and even talk about biopsying, but if it's a sporadic pop up and goes back down, that's typically related to fatty liver and the weight loss. There's always concern with rapid weight loss that it can cause gallbladder disease. This is looking at the incidence in terms of the Nurses Health study that looked at higher BMI levels versus OPTIFAST, and it's actually pretty similar, about 1% a year. So we really don't see a big uptick in gallbladder disease, but any type of rapid weight loss can cause it. But these patients are already at heightened risk because of their obesity. EKG schedule. So we do one at baseline. We repeat it at 4 weeks if there's prolonged QTC. So sometimes you'll see a QTC interval prolonged because of medication effects. A lot of the SSRIs can do that. You'll see it where they have low potassium or low magnesium. For most patients, it resolves within 4 weeks. So we always repeat it, make sure it's not getting longer. And we check whenever medically indicated. So we don't stick to a rigid schedule of checking EKGs. Some older programs would tell you to check at baseline, at the end of the fast, and then again at a year, but there really is no medical justification to check it that often. Constipation and diarrhea, out of the gates here, that first week or two, it's pretty common. So you can talk about adding some fiber, usually some soluble fiber, like some benefiber or Metamucil works well. The bars do have some sugar alcohols in there, which can make it worse, so maybe reduce those. And most patients do fine over time, their body getting adjusted. Constipation, we sometimes often use some stool softeners or Marilax if needed. Managing hunger. So definitely the first couple days is when patients experience the most hunger, typically the first 2 or 3 days. Typically by the end of 7 days when they come in, they're not struggling with hunger at all. And the key here is really talking to patients about sticking to a schedule of every 3 hours. We tell our patients every 3 hours, and we actually write down a schedule with them of how often they should be eating to help prevent them from getting too hungry. Fluid is a good intake. If they need an extra serving, so if they're on 800 calories, they're always welcome to take an additional serving. Distraction, so plan alternate activities, go get busy, go do something, go clean out the closet, go for a walk, and then focus on positive behavior changes. There's your walk. Physiological adjustments, so there's a decrease in food digestion, decrease in hunger cues, volume and enzymes, the GI secretions decrease in gallbladder contractions, so that's what may affect gallbladder disease. Resting energy expenditure goes down, and you can see some changes hormonally and enzyme levels with sustained low-calorie diet. This is a study looking at your metabolic rate compared to a meal replacement weight loss and a slower weight loss. So the meal replacement here was 400 calories a day, so about half of what we do with the current OPTIFAST of 800. And this blue line here I believe was 1,200 calories a day. And then they looked going out 45 weeks. So metabolism is decreased for both patient sets about the same. So this idea that a complete meal replacement or low calorie intake is going to hurt your patient or damage their metabolism is not based on science. The science shows here that the metabolism goes down regardless, just based on weight loss itself. And the weight loss here was about 16 to 19% weight loss. You see a reduction in metabolism. And that's what you see with these other studies, like the Biggest Loser studies. Psychological adjustments. So, there's concerns about eating typical foods, but willing to try. So these are the patients that are at low risk. The patients that really want to get back to regular food, like I can't wait to go back to my favorite burger joint. I can't wait to get my regular pizza. Those are the patients that you really need to work with closely because they're at the highest risk for relapse. If they have that mentality that they want to jump back into those old eating patterns, those old behaviors, those are your patients that are high risk. The other group that's at high risk are these patients that think we cured them. Like, okay, I did the program, I'm done. I don't need to see you anymore. They're at risk, high risk for relapse or weight regain. Your best patients are patients that want to jump back into food, but want to do so with care and close follow-up. So let's talk about jumping back into regular food. So that's our transition. So the transition phase is typically 6 weeks. Many of our patients do much longer than that because they have more weight to lose, and we'll allow patients to do it however long they need to. So this is gradual reintroduction of food. So typically you go from 5 meal replacements a day, which is 800 calories, to perhaps 1 meal with 3 to 4 meal replacements, and then work to adding in snacks and more meals. And you do that over a period of 6 weeks. And the goal is to get to about 1,200 calories for the average patient. Once again, you have to adjust for each individual, but patients are not eating this 2,000 calorie a day diet that everyone thinks the average American needs. Most of these patients need much less calories than that each day. So going back to the transition, you'll definitely see some small weight fluctuations. So as you start adding in regular food, especially food with more sodium, and if they start with this transition doing like these lean cuisines or these other type of pre-prepared meals, they definitely have a lot of sodium in it. So they may see a jump in weight 2 or 3 pounds that first week, and just I try to talk them off the ledge and say that's expected and normal with increased sodium intake and increased carb intake. We still expect them to lose weight on transition if they follow the plan. So I tell them they're going to still lose weight, while they're on this partial plan, but until we get to maintenance or weight management. Transition is the most difficult part of the program, transition and maintenance or weight management. So really keeping these patients engaged, letting them know what to expect in terms of the weight loss numbers, let them know that things are going to slow down is important, because once they start seeing a slowing of weight loss or flattening of weight loss, they sometimes think that things aren't working, so it's time to quit. And as we all know, what happens with that is typically we end up going back up. So definitely going through expectations with your patients. And you want to keep the whole team together. And so we keep patients coming in regularly for all their visits, for all their weigh-ins, and all their classes. So when we get the transition, we don't back off on all the other interventions, all that multidisciplinary team. If anything, we lean in more with the patient because they're going to need more help as we add in more regular food. So maintaining that level of structure is important. The medical visits, we definitely see them less often as they get into transition and weight management in terms of the medical provider. But once again, going back to whatever is medically appropriate for the patient. Some patients I'm seeing, every few weeks during initial transition or weight maintenance. Some patients I may see every 3 to 6 months during that period. It kind of depends on the individual. We still do the weekly visits. We still do weekly group visits with them, which includes the behavior visits. But once again, with these transition clinic visits, it's just, the transition protocol, meaning talking about expectations for the patients. Many patients are actually afraid in transition to go back to eating regular food, so a lot of hand-holding with adding regular food. I have some patients that say they want to stay on the OPTIFAST forever because it's the only thing that ever worked for them, and it's easy, and they don't have to cook. So a lot of these patients, you do have to walk them back into it. But once again, that idea of long-term weight management. And I let patients know that if we need to, we can always go back and use more OPTIFAST as a tool. And a lot of times that's reassuring to the patient to understand that, hey, you're not all done. It's not that you can't use this tool anymore. It's just it's time to eat food and to function on transitioning to maybe some slower weight loss or weight maintenance. And if we ever need to, we can always use the tool again and go back to some OPTIFAST. And then this is a time to talk about medications. So I do prescribe FDA-approved medications for weight reduction. There are, I think, 8 of them out there. We lost one this year with Belviq, but there are medications that can help our patients. And I do sometimes use them during the active weight loss phase. You really need to, though, because OPTIFAST and the plan and program works so well. But a lot of times during transition or weight maintenance is the most important part for using medications, and I'll touch on those. So it talks here about an exit interview. We don't have an exit interview. Once again, I told everyone, we're kind of like the mob, and that's not anything to do with my ethnic background. But once you're in, meaning you need chronic treatment of this disease process with us or someone like us. We want them to continue doing all the healthy behaviors that worked for active weight loss that are going to be helpful for long-term success. So we tell patients, the journaling, the exercise, the tools that you're doing during active weight loss, those are things I want you to be able to do in weight maintenance. So I tell patients that if you're exercising twice a day, 6 days a week during active weight loss, unless you're going to do that for the next 50 years and through weight maintenance, don't even bother. So we want to develop these habits during the weight loss phase, so that way when they get to weight transition and maintenance, that they can maintain doing those. Make this specific to your patient, but 1,200 kilocalories a day is typically a starting place for a lot of our patients. We do allow patients in weight management to use OPTIFAST 1 to 3 times a day. If you look at data from the Look Ahead trial, long-term use of meal replacements to help patients maintain weight loss, the patients do well. So, we have our patients, attend for a lot more than 1 year, but at least 1 year is considered appropriate and minimum follow-up for someone for weight management. Once again, we may use meal replacements ongoing. Studies indicate that over-the-counter partial meal replacements are shown to extend, even using partial meal replacement long-term helps with weight loss, at least 4 years. And servings are typically 1 to 3. So these are based on studies that have been performed and done, and once again goes to the science behind the OPTIFAST program. And this is some of the data you can look at. So, you're looking at the majority of weight loss at 5 years, about 75%, medically significant weight loss, 50% at 5 years. So that's, medically significant at least 5%. And a lot of this is dependent on how close your patients follow up with you. If you follow your patients long-term and treat this as a chronic disease, patients will do well. If you tell them they're fixed after 6 weeks of transition, see you later, most of them will regain. Factors that correlate with long-term success, basically all the things that you see on these weight control registries, longer term in treatment, physical activity, weekly weighing, meal replacements if they're struggling, and timely lapse intervention, once again, being open doors so they can come back in. Work on patients with their behavioral skills, specifically stimulus control, restructuring, stress management. We have a social worker that sees a lot of patients one-on-one for problems with chronic stress, time management. So let's talk about pharmacotherapy. So this is not going to be a pharmacotherapy lecture, but I'll just touch on the medications that we use for help with weight loss. These are the FDA-approved medications for weight loss. So that first one, Xenical, it's also the same thing as Ally. Ally is available over the counter. Xenical is a prescription. This is the fat blocker. You have Contrave, which is a combination of 2 older medications, an antidepressant and an opioid blocker. Qsymia, which is a combination of phentermine and topiramate. Topiramate's a medication used for seizure disorders or migraine headaches. Saxenda, which is liraglutide, which is the same active ingredient in Victoza, which is a GLP-1. And these are all indicated for long-term treatment, meaning you can use them indefinitely. That's considered FDA approved use. There are medications, some of the older ones called some pathomimetics. These are all back from the 60s and 50s and 60s. And these are indicated for short-term use for up to 12 weeks. Managing weight relapse, there's that favorite term of mine. So a lot of times it's easy to fall into old past behaviors, especially when patients are stressed. So definitely having that open door, no shame, no blame. We do periodic phone calls to patients. So if we have a patient that went into maintenance and we haven't heard from them in 3 or 6 months, we'll put a call out there, an email, ask them how they're doing, let them know they're always welcome to come back in. Strategies to help lapsing patients. So determine where they are. I mean, do they need to come in? Is it a complete collapse? We need to restart the whole program again. We've done that with patients a number of times. Looking at the causes and try to build tools into their life so they can handle this better in the future. And that's where a lot of these behavioral classes come into play. Move forward, not always looking back. And I tell patients, use your tough moments, the moments when you struggle the most, as an educational opportunity to learn to do better in the future. Program reentry. So, if they've been gone for a while, we'll often have them come back in for another complete evaluation. If they've had significant weight regain, we'll have them come in for another complete course of treatment. And it basically just depends on, where they've been, what's changed in between our last visits. Typically over 12 months, we kind of almost treat them like a new patient if they haven't been seen in 12 months. The program can also be used to help with bariatric surgery. So we do see a lot of patients pre-surgical. So we do know that using complete meal replacements pre-surgically can provide some benefits. Reduced fatty liver, decrease in liver size, some pretty significant weight loss in that 12 weeks. And so when we see patients here and they're in the pre-op pathway, we do use OPTIFAST as their 2-week pre-surgical meal replacement, even if they're not doing OPTIFAST initially. And there's been some great studies in terms of looking at reduced operative time and some better outcomes. So once again, just looking at more bariatric surgery outcomes, 26 pounds in 12 weeks, reducing fatty liver. All right, summary. You all made it to the end. So OPTIFAST can be an important tool for long-term weight management. Really, the program needs to be individualized to the patient, but there are definitely guidelines that we can utilize to help get patients rolling and provide a safe and effective environment for them for weight loss. Definitely recommend anyone using an OPTIFAST program develop a good, strong, long-term weight management option to help them maintain their weight loss and have an open door policy for getting patients back in if they need help. And there are other resources out here. The medical guide and OPTIFAST nutrition guides. The medical guide has a lot of different charts in terms of the medical monitoring. The only thing I recommend there is use your medical judgment for that. The nutrition guide has all the information about all the products in terms of what's in them, in terms of the nutritional breakdown.